Dear colleagues, it gives me a great pleasure to be here today to discuss our most recent ASGE guidelines entitled ASGE Guideline on Screening for Pancreatic Cancer in Individuals with Genetic Susceptibility. I'm glad to be joined today by my good friends and SOP members on the Standards of Practice Committee and lead authors of this guideline document, Dr. Mandeep Sawhney and Dr. Audrey Calderwood. Thank you guys for coming here and for doing this. I certainly enjoyed doing this guideline. This is going to be our first ASGE guideline for which we are doing this GIE author interview. And this will be a series of interviews that we will try to do on all of our guidelines to try to spread awareness about our guidelines. Our goals today is to, again, spread awareness of our new guidelines and foster a better understanding of the evidence-based recommendation that we have. As you know, guidelines are very important because there's been a lot of studies that show that adherence to guidelines can improve disease outcomes, improve quality of care, and lower the cost of healthcare intervention. So I will tell you briefly before we start this discussion about the process of doing this guideline and all of our great guidelines that we have been publishing in ASGE. We try to follow a very rigorous methodology called the GRADE methodology, which involves using systematic reviews and meta-analyses and reviewing all available medical literature. And we have many considerations when we make recommendations, including assessing the scientific evidence, but we also look at adverse events, cost effectiveness, patient values and preferences, among other factors. So these guidelines take a lot of time to produce. Between the time we conceptualized this guideline and the time we published it, it at least took about a couple of years for it to be available. Please remember that guidelines are not a substitute for physicians' own opinion and the patient's own preference. And the final decision on screening versus no screening should always be based on those factors, in addition to local expertise. So guys, again, thank you for being here, Mandeep, Audrey, and I know we have had many meetings about this guideline, and this may be our final meeting to discuss it one last time. I certainly enjoyed this process. Can you tell us and tell everyone about how this came about? Because this is a different guideline than the ASGE is used to coming up with, because it relates to screening and not necessarily the role of endoscopy. So do you want to tell us a little bit about how and why we decided to do this guideline?
Sure. Thanks for having us, Bashar. It was a lot of fun to work with Mandeep and you and the other members on this guideline. So we were really interested in addressing screening for pancreatic cancer because we felt like that was an area that just needed more guidance for our fellow endoscopists and gastroenterologists who see patients at high risk or worried about being high risk due to family history or genetic mutation. And there wasn't much out there. Previous guidelines were really all opinion or expert consensus based and not based on this rigorous GRADE methodology that you've described. And we felt like there was ripe enough data to be synthesized in a formal systematic review and meta-analysis. And we really wanted to provide methodologic rigor to the findings and recommendations. The other sort of impetus for this was, while thinking about this topic, the U.S. Preventative Services Task Force came out with a statement on pancreatic cancer screening for average risk individuals, where they did not recommend it with a grade D. And so we felt that timing was right to provide guidance for groups in whom screening could be beneficial, recognizing that we see those types of patients in our clinical practice.
Yeah, thank you, Audrey. I think you are very right, because even though our guideline is still not yet completely published in print, we have seen a lot of interest about this topic. I recently was in a national meeting here, and this issue does keep coming up in the meetings of who do you screen, when do you screen them. So I do think this is going to be a very timely guideline. Thank you so much. Okay, what do you guys think when we started thinking about this? What were some of our specific aims that we kind of wanted to address in this document.
Sure. So what we wanted to do was to provide evidence-based guidelines for pancreatic cancer screening in individuals who are at increased risk of pancreatic cancer due to genetic susceptibility. So like Audrey mentioned, the US Preventative Services Task Force had looked at the issue of pancreatic cancer screening in the general population and determined that screening was not recommended. So now we wanted to look at the high-risk population and see whether screening could be beneficial to them. And as you pointed out, we wanted to use an evidence-based methodology. The other thing we wanted to do was to look at the harms of pancreatic cancer screening and also look at the outcomes of pancreatic cancer screening in this patient population.
Very good point, Mandeep. And since you mentioned it, I'll kind of ask us to maybe explain to our listeners, what do we mean by the harms of this screening? How did we go about measuring the harms of screening and defining them and looking at them in a systematic way? Because we've done a thorough job, kind of. We've spent many hours looking at this specific questions. What are the harms of screening? How do we define them? How do we measure them? You guys want to tell us a little bit about how we did that?
So, we did a systematic review and meta-analysis of all pancreatic cancer screening studies in the literature, and we found 25 such studies. And then we looked at harms of pancreatic cancer screening in 3 different ways. The first thing we looked at was what are the harms of EUS and MRI, which are the 2 modalities that we use for pancreatic cancer screening. And we found that both these modalities are actually very safe, and there are very few harms that result from MRIs or EUS. The second thing we then looked at was surgery that resulted from a positive pancreatic cancer screening test. So what we found was that about 5 or 6% of patients who are entered in a pancreas cancer screening program will undergo surgery. About 40% of those pancreatic surgeries are what we call low yield surgery. And a low yield surgery is a surgery where we don't find cancer, we don't find high-grade dysplasia, or we don't find a high-grade Pann lesion. In other words, surgeries that are not likely to benefit the patients. So that's another possible harm of pancreatic cancer surgery. And the third way we looked at harms was we looked at complications or adverse events from those pancreatic cancer surgeries, and those occur in about 20% of patients who undergo pancreatic cancer surgery. So these were the 3 ways in which we defined harms from pancreatic cancer screening, and we suggest that physicians discuss these very carefully with their patients before they enter patients into a screening program.
Definitely, Mandeep, as you correctly pointed out, we looked at this in a couple of ways. One, looking at everybody who had screening, and we found that the incidence of overall harms, i.e. if you had surgery, but you really did not need to have surgery, was very low, like you said, maybe less than 6%. So the vast majority of people who will undergo screening are not going to have an adverse event from screening. But in fact, the patients who had surgery, a good number, about 40%, did have surgery for maybe that was not very indicated. But we also discussed that some of these studies may have been older studies, and this currently is not the current practice. Isn't that the case?
That's correct. Our group published a series of patients undergoing pancreatic cancer screening who underwent surgery. And in our group, the rate of surgery was only 2%. And in both patients, one patient we found pancreatic cancer, and the other one we found high-grade dysplasia. So I think a lot of studies harken back to a time when we thought that even small cystic lesions in the pancreas, in these high-risk lesions, are worrisome and they should be operated upon. But now we have a better understanding of the problem. We don't think that small cysts in high-risk patients require surgery. So I have no doubt that over time we'll see a marked drop in the rate of low-yield surgeries in these patients as we get a better understanding of how to sort out who goes to surgery and who can be carefully followed.
Definitely. So the take-home point here is that most patients who have screening will not undergo surgery. The vast majority will not, and a small proportion will, out of whom we expect only a small proportion of them to have unindicated, if you will, or surgery for what we call low-yield lesions. Excellent. Okay, so Do you guys want to maybe highlight for us? I know our guideline is a bit different. Some of our recommendations differ from previous recommendations. Maybe we should highlight how our guideline is different. And I guess one of the most important differences is that a lot of the screening that we are recommending is not based on having also the genetic condition and in addition a family history of pancreas cancer. Do you guys want to tell us a little bit about that and how is that different from other guidelines, and why did we feel that we need to make such a recommendation in the absence of family history? Because I think this is a key difference between this guideline and previous guidelines.
Yeah, I think that's definitely worthy of highlighting. So as we've discussed, we highlighted on conditions where patients had genetic susceptibility with a particular focus in BRCA2 and BRCA1 based on how common they are and how much of pancreatic cancer that they are affiliated with. So in order to find this, we did perform separate systematic reviews and a meta-analyses of BRCA1 and BRCA2 patients to quantify the risk of pancreatic cancer in these kindreds. For BRCA2, we had like 11 studies. For BRCA1, we had 4 studies. And we were able to quantify like relative risk and then extrapolate that to a predicted lifetime risk of pancreatic cancer. And the relative risk was about 5, the standard incidence ratio about 7. So that was associated with the cumulative lifetime risk of about 5 to 7%. There were far fewer studies for BRCA1, so only 4. And in that we found the relative risk was 1.9, almost 2, standard incidence ratio of 3.7. So that lifetime risk was estimated to be anywhere from 2 to 3.8%. Now, interestingly, for all the studies we looked at, there really was very limited reporting of family history of pancreatic cancer. And so as you alluded to, previous recommendations around screening for pancreatic cancer in BRCA1 and BRCA2 patients highlighted that there should be a family history of like a first-degree relative with pancreatic cancer. We weren't able to draw conclusions about family history from the studies included in our analysis, but we had other supporting studies that showed that if screening was limited to BRCA1 or BRCA2 patients with a first-degree family member with pancreatic cancer or any family member of pancreatic cancer, we would only detect about 33% of cancers, so meaning 2 out of 3 pancreatic cancers would be missed. And so now that the pedigrees are smaller and many people don't know their complete family history, it may be more rare to have a family history of pancreatic cancer in these conditions. And then another reason why our recommendation differed was because there's more and more data showing that BRCA-related pancreatic cancers seem to be particularly responsive to particular regimens of chemotherapy, especially in like borderline resectable cases that may become resectable, and also prolonged survival in advanced disease. So it seemed like identification and screening in BRCA patients is becoming more important for these reasons. Mandeep, do you have anything to add to that?
Yeah, Mandeep.
There were 2 other issues that I think I'd like to highlight. One is the targets of screening. So previous studies had suggested that only if you find a T1 cancer or high-grade dysplasia or high-grade PAN could you call that a success of screening. And in our guideline, we've enlarged or we've increased the targets of screening to say that finding a resectable or a borderline resectable pancreatic cancer is a reasonable target for screening, because these are cancers that, as Audrey mentioned, with chemotherapy, especially in the BRCA patients, can be downstaged and go from being inoperable to operable. So these are cancers that we can have a significant impact. So I think these are adequate, or these are acceptable targets of screening. The second thing that we found evidence that pancreatic cancer screening can result in psychological benefits. So we found evidence to suggest that patients who undergo pancreatic cancer screening have less cancer worry and less cancer anxiety compared to those who don't get screened. So that's another positive finding towards screening.
The other one, and if I'm not sure if you mentioned this, was the downshift from cancers when we looked at the SEER database. And the survival was improved, although it was not directly compared, but the survival in patients who had screening detected cancer was significantly different, at least indirectly, when we compared it to survival in pancreas cancer altogether. Do you want to talk about that a little bit?
Sure. So I think that seems to be the biggest benefit of screening. So when we looked at the proportion of screen-detected cancers that were resectable or borderline resectable, that number was about 60%. And when you look at the same number for symptom-detected cancers, that number is only 20%. So we found strong evidence to suggest that when you screen patients for pancreatic cancer, you find them earlier, and a larger proportion of them are resectable or borderline resectable, which is a positive thing. And then, as you mentioned, we found 2 studies that showed that the outcomes of screen-detected pancreatic cancers are superior to symptom-detected pancreatic cancers. The most well-known studies by the Johns Hopkins group that followed over 300 patients with who were high risk for pancreatic cancer. And what they found was that the 3-year survival of screen-detected pancreatic cancers was 85%, compared to only 25% of those patients who stopped screening or who were non-compliant with screening. So again, suggesting that screening can improve outcomes in patients.
Very good points. It's also, we should mention that we did not find, obviously, any randomized trials on screening versus no screening. All of the data we have used here was more or less indirect, but we have made a compelling case based on everything we just discussed that screening, the benefits of screening in this patient population outweighs the risks. We've also chosen the 5% cutoff that other studies have used for your cumulative risk or lifelong risk of developing cancer to decide which population should have screening versus not. All right, excellent points. I think this is highlighting very nicely some of the major points that we have discussed. Having now showed that there is a benefit for screening in this patient population, we also looked very carefully and methodologically at the question of how we should perform screening, i.e. Most common used methods are either an MRI of the pancreas and EUS. Do you guys want to tell us about what we did and how we came up with the recommendation here?
Sure. So we did a meta-analysis and a systematic review of the 25 pancreatic cancer screening studies, and we divided those studies into 3 groups. So group 1 was studies that used only EUS for screening, group 2 was only MRI for screening, and then the 3rd group used a combination of EUS and MRI for pancreatic cancer screening. And then we looked at the yield of screening in each of these groups, and we did not find a significant difference. There was a slight trend towards EUS being better than MRI, especially when it comes to detecting solid lesions of the pancreas. There were a few studies where almost all solid pancreatic lesions were detected only by EUS, but none of these results reached statistical significance. So based on that, we recommended that you can use either EUS or MRI or a combination of EUS and MRI for pancreatic cancer screening, based on patient preferences and local expertise.
That's right. But Mandeep, we also, and Audrey, we also highlighted maybe some specific instances in which EUS is preferable or MRI is preferable. Do you want to tell us what we found maybe for each of those briefly?
Sure. So if you can combine EUS with another indication for endoscopy, then we suggest that you do EUS. An example of that would be someone with Peutz-Jeghers syndrome who also needs an upper endoscopy and a small bowel exam to look for polyps. In those cases, you can combine that with an EUS. Patients who have contraindication to MRIs like claustrophobia or kidney disease, those again would be good candidates for EUS. And on the flip side, patients who put a high priority of not undergoing invasive procedure or anesthesia, or who have contraindication to anesthesia, those would be good candidates for EUS. We found one study that suggested that if you do EUS, you should probably use a linear echo endoscope. And then on the MRI side, we found data to suggest that if you do an MRI, do it with contrast, get formal MRCP series, and then some data to suggest that using a 3 Tesla magnet might give you superior images to a 1.5 Tesla magnet.
I should also mention, and part of our panel did include a radiologist as well, who also helped us weigh in on some of these issues. So we thank him very much for that. We also spend a lot of time discussing the frequency of screening and the age, and how should we decide the age at which you start screening and how often you should do the screening. Do you guys want to kind of summarize for our audience here? Because we use some specific kind of methodology to come up with the age at which we should start screening and of course the frequency. So let's start with the age of screening for the different conditions. What kind of methodology did we use to decide when you should start your screening?
Yeah, so our group thought it was important to develop some kind of rule a priori before delving through the evidence. So to figure out what age to start screening, a lot of other recommendations have used 5 years or 10 years before first affected family member. We looked at sort of the median age of presentation of pancreatic cancer for each of the conditions of genetic susceptibility. And then we looked at the distribution based on standard deviations. And so I think, and please correct me if I'm wrong, Mandeep, we did one standard deviation, is that right, for below the median age for most of the conditions. And then if they're particularly high risk conditions, for example, like FAM or something, we did 2 standard deviations below. And so in some cases, it actually did work out to 10 years, but that was the underpinning of our rationale and sort of methodology for doing it. So in our guideline, there is a nice chart that shows for each of the conditions what age to start at. And then in terms of the frequency, we really looked at all of the studies included in our 25 studies of the meta-analyses to see what intervals were used. And most everyone used annual. And so that's why we suggest doing it at an annual basis, whether it's MRI, EOS, or alternating, as Mandeep discussed.
Yeah, we also, thank you, Audrey. We also found data that most pancreas cancers do progress from, I guess, stage 1 to stage 4, 3 or 4, correct me, Mandeep, within a year. And that's why we thought if you are going to have screening, then it should be done annually. Is that the case?
That's correct. So we found 2 studies. One modeled the age of diagnosis of early cancers and compared them to the age of diagnosis of later cancers. And then the second study was an interesting study that looked at CAT scans that had been done in the months prior to the diagnosis of pancreatitis. And then a radiologist with hindsight went back and looked at those CAT scans to see how often a lesion suspicious for pancreatic cancer might have already been visible. And both those studies suggested that pancreatic cancer can go from early stage to late stage within a year to a year and a half. And based on that, we recommend an annual screening.
Very good, excellent. And like you guys said, we do have a nice table with all these recommendations. That is, you can easily use that to reference these conditions and to see what age you should start screening. Again, we would recommend or suggest screening to be done by EUS or MRI and to be done annually. I do want to make some final comments that all of our recommendations were conditional recommendations. As I mentioned before, none of the studies that we reported here were randomized controlled trials. And so the evidence was mostly from indirect evidence, as we have pointed out. Conditional recommendations mean that most individuals with these conditions would want to go the suggested intervention, but some of them may not. We always want to remind our audience to please factor in the patient's values and preferences. And as Mandeep alluded to, and we talked about this, there is strong data suggesting that initiating a screening program does have psychological benefits because patients do feel like they are doing something proactive about it, and that gives them control. So that's important, but some patients may not want to have screening. And so it's important to have this discussion with the patients before you initiate a screening program. Thank you both very much for your hard work. You've done a great job. I really enjoyed working together on this guideline. I think it's going to be very well received. Most importantly, I think it's going to help a lot of patients and hopefully screen patients, detect cancers when they are early, and save lives, as this is our goal. Many thanks to all of the standards of practice members, the patient advocate, and our panel of experts who helped us during this guideline process, the ASGE editorial board and the governing board who also contributed and approved this guidelines. If you have any questions about this guideline or any other guidelines from the ASGE, please feel free to email me or email the ASGE. You can find this on our website. Please remember you can download all of our guidelines on the ASGE website for free by going to the guideline tab. Thank you guys so much for being here, and we look forward to having this come out in print soon.
Thank you.
Thank you.
Thanks, guys. All right, excellent.